Let me paint you a picture. You're 74 years old. You feel great. You sleep through most nights. Your energy is decent. You're doing things you enjoy. You walk into your doctor's office for a routine annual physical. Your doctor glances at the chart and says, "You know what? Let's just run a few extra tests to be safe." 6 weeks later, you're sitting in a surgeon's waiting room. Not because anything was wrong with you, but because those just to be safe tests found something. And that something set off a chain of events your 74-year-old body was never designed to handle. That story plays out every single day in this country. And what I'm about to tell you might be the most important conversation you ever have before your next doctor's appointment. Let me tell you about a patient I'll call Eleanor, 74 years old, retired school teacher, independent, sharp, still drove herself to church every Sunday. Eleanor walked into a routine checkup feeling completely well. Her doctor, following standard guidelines, ordered a full panel of preventive screens. One of those tests came back with a small abnormal finding. What followed over the next 9 months was a cascade nobody predicted. 3 more tests, 2 specialist referrals, 1 minor procedure that caused a minor bleed. The bleed required medication. The medication caused dizziness. She recovered, but she was never quite the same. The original finding from that very first test was eventually determined to be clinically meaningless. It was never going to hurt her, but the process of investigating it did. I'm Dr. Marcus Okoro. I'm a heart surgeon. I've spent the last 20 years inside operating rooms watching what happens to senior bodies when the medical system runs on autopilot. And what I am about to share with you is something most doctors will not say out loud during a 15-minute appointment. After the age of 65, some of the most common routine tests your doctor orders can quietly cause more harm than good, not because medicine is broken, but because the risk-to-benefit math changes dramatically as we age, and almost nobody is doing that math in the room with you. Today, I'm walking you through 5 specific medical tests I would personally think twice about after the age of 65. I will tell you why. I will share what I have seen happen. And at the end, I will give you a 5-question protocol that you can write down and bring to every single doctor's appointment for the rest of your life. Stay with me through all 5, because test number 3 is the one that catches most seniors completely off guard. And the 5-question protocol at the end is the part that will change your healthcare experience permanently. But before I get into the 5 tests, you need to understand one concept. Without it, nothing I say next will fully land. I call it the Cascade effect. Here's how it works. You go in for a routine test. The test finds something. The something looks like it might be a problem, so your doctor orders a second test for a closer look. That test finds something slightly different. Now there's a referral to a specialist. The specialist recommends a small procedure just to be sure. The procedure causes a complication. The complication needs treatment. The treatment has side effects. And 6 months later, a person who walked into a clinic feeling completely fine is now managing 3 new diagnoses, 2 new medications, and is less functional than when the whole thing started. I have watched this exact sequence happen more times than I can count. Not because doctors are careless, but because medicine is designed to find things. And once something is found, the system is built to respond to it. The problem is that not every finding in an older body needs a response. Here's the second thing you need to understand. Most medical screening guidelines were developed using research on younger adults. They were then extended upward to apply to older patients. Without specific evidence that the same math works at 70, the risk and benefit calculation that makes a test sensible at 50 can look completely different at 75. And that recalculation almost never happens automatically. With that in mind, let's get into the 5. Test number 1, routine cardiac stress testing in a patient with no symptoms. This is the one I see most often, and it sounds so logical. Your doctor says, "You're 72, let's just make sure your heart is doing okay." You hop on a treadmill. Or they give you a medication that temporarily stresses your heart and they monitor the response. Sounds responsible, sounds preventive. Here's the problem. Cardiac stress tests in people without symptoms have false positive rates that can reach 40% or higher in certain populations, particularly in women over 65. That means nearly half the time the test flags an abnormality when your heart is actually fine. And medicine cannot shrug at an abnormal finding. That false alarm launches you into the next phase, which is almost always a cardiac catheterization. So you've gone from feeling perfectly fine to a routine test, to a false alarm, to an invasive procedure with real risks. As a heart surgeon, I will tell you directly, if you have no chest pain, no unexplained shortness of breath, no dizziness during activity, no fainting episodes, Routine stress testing is looking for problems in a population where problems are common, but where intervention does not always help. The smarter conversation with your doctor is about optimizing your modifiable risk factors: blood pressure, cholesterol, blood sugar, activity level, sleep quality. That is where the real heart health gains are after 65, not on a treadmill that flags a false alarm. Test number 2. And I'm going to be very honest with you here because this is my actual operating room. Aggressive cardiac catheterization after a positive stress test in a patient with no cardiac symptoms. This is the test I would push back hardest on. Here is how this scenario typically unfolds. A patient over 65 goes for that routine stress test. No chest pain, no shortness of breath, no symptoms of any kind. The test comes back with an abnormal reading. The cardiologist recommends cardiac catheterization, a procedure where a thin tube is threaded through an artery in the wrist or groin, fed all the way up to the heart, and dye is injected. Catheterization is invasive. It carries real risks for older patients: bleeding at the insertion site, arterial injury, kidney damage from the contrast dye, which is particularly serious in older patients with reduced kidney function, and a small but real risk of stroke during the procedure itself. Here is the devastating finding from 2 landmark studies, the Courage trial and the Ischemia trial, both published in the New England Journal of Medicine. In patients with stable coronary disease and no significant symptoms, aggressive intervention through catheterization and stenting did not reduce the rate of heart attack or death compared to optimal medical therapy alone. Let me say that again. The stent did not help more than the medication, but it carried real procedural risks. And then a lifetime of blood thinners with their own bleeding complications. So a senior with no cardiac symptoms can go from feeling fine to a false positive stress test, to a catheterization, to a stent, to ongoing medications, and statistically be no better off than someone who just took the medication and walked 30 minutes a day. Before you ever agree to a cardiac catheterization, ask your cardiologist directly, do I have any symptoms? And if not, what does the evidence show about outcomes? For people like me who are managed with medication compared to those who go through with the procedure, the answer should be a real conversation, not a referral slip. Test number 3, carotid artery ultrasound in a patient with no symptoms. The carotid arteries are the 2 large blood vessels in your neck that carry blood to your brain. They can develop fatty plaque deposits over time. Carotid ultrasound scanning is sometimes ordered as a routine stroke prevention measure for older patients. On the surface, it sounds completely sensible. Find the problem. Fix it before a stroke happens. That logic is appealing. The evidence does not fully support it. Here is the critical issue. The procedure used to treat a significant carotid blockage is called a carotid endarterectomy. The surgery itself carries a stroke risk of 2 to 3% during or immediately after the operation. In older adults, that risk is higher. The United States Preventive Services Task Force, which is the gold standard body that sets American screening guidelines, has explicitly recommended against routine carotid ultrasound screening in adults who have no symptoms. Their analysis found that in symptom-free seniors, the surgical risk of stroke can equal or even exceed the stroke risk of doing nothing and managing the patient with blood pressure and cholesterol medications. In plain language, the test finds something. The something gets operated on. The operation can cause exactly the event it was supposed to prevent. The smarter strategy is to control your actual modifiable stroke risk factors. Blood pressure, the single biggest stroke driver. Atrial fibrillation, cholesterol, smoking, activity, diet. If you do have any symptoms of stroke or what is called a transient ischemic attack, sudden weakness, sudden vision change, sudden facial drooping, sudden severe headache, even one that resolved on its own, that changes everything, get evaluated immediately. But if you are asymptomatic, ask your doctor whether the ultrasound is really necessary or whether optimizing your medications would do more good. Now let me pause here for a moment. We are halfway through the 5 tests, and I want to ask you something. Have you ever had a routine test that led you somewhere completely unexpected? A test that found something that triggered another test, that triggered another, until you ended up dealing with a problem you didn't even know you had until the system created it? If yes, please share that experience in the comments below. I read every single one of them, and your story might be exactly what someone watching this video needs to hear before their next appointment. And while you're there, please hit the like button. It tells YouTube to show this to more seniors who need to hear it. Test number 4, routine full-body CT scans. You get a full scan from your neck to your pelvis. The machine checks everything. You walk away knowing exactly what is happening inside your body. It sounds like the smartest thing you could possibly do for your health. When you scan an entire body at 65 or older, you will almost always find something. Not because something is actually wrong, but because human bodies accumulate harmless changes with age. Small nodules in the lungs that have been there for decades without ever causing a problem. Tiny cysts on the liver or kidneys that are completely benign. Minor age-related changes in the spine. The medical term for these is incidentallomas. Whole-body CT scanning has been marketed heavily to health-conscious adults as the ultimate preventive health tool. A small lung nodule means follow-up CT scans every 6 months for 2 years. That is a significant accumulating radiation dose to a body that already repairs DNA damage more slowly than it did at 40. A study published in JAMA Internal Medicine found that whole-body CT screening led to further diagnostic testing in 37% of participants, and that most of those findings were ultimately clinically unimportant. Meanwhile, the downstream testing caused real complications in real people. The radiation from a single whole-body CT scan is roughly equivalent to 3 years of natural background radiation. Findings discovered by accident that were never causing symptoms and were never going to. But once the scan report names them, your doctor is professionally obligated to investigate. The cascade begins. Repeated scans compound that exposure. The single question to ask before any CT scan is, do I have specific symptoms this scan is intended to investigate? If the answer is no, think very carefully before you agree. If you have rectal bleeding, unexplained changes in your bowel habits, unexplained weight loss, or a family history of colon cancer, the math is completely different, and a colonoscopy may be exactly the right call. What I am addressing is the routine screening scope in an asymptomatic, average-risk senior over 75 who has had previous clean exams. The USPSTF officially recommends against it. The evidence is clear. After 75, if you have no symptoms, no family history, and clean previous scopes, the risks begin to outweigh the rewards. And those risks are real. Bowel perforation, a literal tear in the colon wall, occurs in roughly 1 in every 500 colonoscopies. In a younger adult, that is a manageable surgical complication. In a 77-year-old, it can mean emergency surgery, extended hospitalization, and a recovery that fundamentally changes quality of life. The colonoscopy prep itself, drinking liters of liquid the night before, can dangerously dehydrate older adults and crash electrolytes. Test number 5, routine colonoscopy after the age of 75 in average-risk seniors. Now please hear me carefully. I am not telling you to ignore symptoms. If you are over 75 and your doctor is recommending a routine repeat scope, ask about a non-invasive stool-based test instead. The Cologuard test or the annual fecal immunochemical test, the FIT test, can flag genuine warning signs without the procedural risk. Meanwhile, the colon cancers most commonly found in asymptomatic seniors tend to grow slowly, in many cases, slowly enough that they would never cause problems within the patient's remaining lifetime. Those are the 5. Now here is the part that matters most. I promised you a 5-question protocol that will change every doctor's appointment for the rest of your life. Take out a piece of paper. Write these down. Bring them to every appointment. Every time your doctor recommends a screening test after the age of 65, especially if you are feeling well, ask these 5 questions, exactly in this order. Question 1. What is the false positive rate of this test in people my age? This tells you how likely the test is to trigger unnecessary follow-up. Question 2. If the test finds something, what are the realistic treatment options for someone my age and my health status? This forces the conversation toward real outcomes, not just findings. Question 3. What is the procedural risk of any treatment we would likely pursue? Every procedure has a risk. You deserve to know it before you start. Question 4. What happens if we monitor this instead of treating it? For many conditions found in older adults, watchful waiting with regular monitoring is a legitimate and often superior option. Question 5. What is the most effective non-procedural intervention for this condition? Because very often, lifestyle and medication outperform procedures, with far less risk. Any good physician will welcome these questions. They will respect you more for asking them. And if your doctor dismisses these questions or makes you feel difficult for asking, that is important information about whether that doctor is the right fit for you. Aggressive cardiac catheterization in patients with no chest pain, carotid artery ultrasound without symptoms, full-body CT scans, and routine colonoscopy after 75 and average-risk seniors. None of this means avoid your doctor. I will say that as clearly as I can. Preventive medicine saves lives. Blood pressure management, diabetes control, vaccinations, vision and hearing checks, annual medication reviews. These are real, valuable, important. What I'm asking you to do is go to those appointments prepared. Bring the 5 questions with you. Use them every single time. Here's what I want you to do tonight. Just one thing. Write down those 5 questions on a piece of paper and put it in your wallet or your purse. The next time your doctor recommends a test, pull it out. Ask. Listen carefully to the answer. If the answer is clear and confident, proceed with confidence. If the answer is vague or dismissive, that itself is telling you something important. You have spent your entire life earning the right to be at the center of decisions about your own body. I'm a heart surgeon. I post a new video every week with the kind of honest health information I share with my own patients. Things you almost never hear in a 15-minute appointment. If this video helped you, please do 2 things for me. First, share it on Facebook right now and tag one person you love who is over 65 and goes to every scheduled screening without asking a single question. The most important thing you can do for their health today might be giving them the one tool that changes everything. Second, please subscribe to this channel. Everything I shared today is general health education, based on published research and clinical guidelines. It is not personal medical advice for your specific situation. Every person's health history is different, and some individuals may have legitimate reasons why these screenings are absolutely appropriate for them despite their age. Before making any change to your scheduled medical care, please have a thorough conversation with your own physician. This video is a starting point for that conversation, not a replacement for it. I am Dr. Marcus Okoro. You deserve the full picture always. I will see you in the next video.